Good afternoon, everyone. Thank you for joining us today. My name is Julie Tesh, and I am President and CEO of the Center for Rural Policy and Development. I have to tell you today that I am doing this webinar from the public library in my hometown of Waldorf. And so for those of you that don't utilize the public library, you really should. I know on my family farm, our internet is not the greatest. And so being able to come to the public library on a rainy day is really helping being able to do this webinar. So just a big plug for public libraries out there, especially in our rural areas. Thank you again for joining us today. We have about 150 people registered for this webinar today. So we're very excited, and a lot of new people that are registered as well. New that they're in the EMS area that have not been on one of our webinars before. So I'm going to give just a very quick overview of the Center for Rural Policy and Development, and then we're going to get right into the meat and heart of it. But the Center for Rural Policy and Development, we were created in 1997, and we were created to do research on issues important to rural Minnesota and how they affect policy. So we do research. I think we do it quite well. And we turn that research over to decision makers like state legislators, county commissioners, township board members, city councilors, things like that. And they take that our research is non-biased, nonpartisan, it's trustworthy, they can take that research and make wise policy from that. So for the majority of our research reports, we do a webinar, just like we're doing right now. We started doing this right when the pandemic started 2 years ago, a little over 2 years ago. And we have found out that having a webinar really does help people understand the reports more. And so very excited that we can do this. We also have, besides our webinars, we also have we have a podcast, we have videos, we have a YouTube channel. You can look us up at Center for Rural Policy and Development. Our podcast is called The Center of Everywhere, and that's on all major platforms. And then we also have a blog, and we have a newsletter. So I encourage you, if you're not receiving our monthly or every other month newsletter, you can go onto our website, ruralmn.org, and there'll be a pop-up there, and you can sign up for our newsletter. We promise not to spam you. What will basically happen is you'll get an email for our newsletter occasionally, and you'll get invited to the webinars just like this. So I encourage you to go to our website, ruralmn.org. With that, we're not going to waste any time. Actually, I will mention one quick other thing. This is being recorded, and so this will be posted, this video will be posted on our YouTube channel in the coming days. I would say by early next week. You can also find us on Twitter and on Facebook. So make sure to check us out there to keep up. We have a wealth of information coming out here in the next 6 weeks. We have reports on access issues in childcare in the BIPOC community, immigrant and refugee populations in rural Minnesota. We have a water resource report coming out. We have childcare solutions, another COVID report, just a lot coming out. And so I will also, last thing I promised Kelly to mention is that all of our research and reports are free to use. So please use them. Use them as you see fit for grants, for presentations. Also, all of our videos, everything that we post online is free for you to use. So please feel free to use that. All right, without further ado, I'm going to turn it over to our lead researcher on our rural EMS project, Kelly Ash. Kelly, take it away.
Thanks, Julie, and thanks everybody for joining. It's a pleasure to present the newest research we have at the Center for Rural Policy and Development about rural EMS. I'm just going to give you a little bit of context of our approach on this research. First, the purpose, we really wanted to take some time to synthesize the challenges facing rural EMS. So this means kind of gathering both the challenges and issues that rural EMS in Minnesota is facing, but as well as the context in which they work in and in which their money financial situations arise. And then also identify priorities for state investment. As many of you probably know, the state legislature is having a rather significant conversation around EMS in general, connected to the Office of Legislative Auditors report, which I'll talk about in a little while here. And so we just kind of wanted to identify some priorities as they're starting to have those discussions about, okay, where could we invest in and what might be the best approach. Research methods, we always do a literature review just to kind of get ourselves, we're not specialist researchers. I always tell people, in academia, their knowledge base is an inch wide and 400 miles deep. We're 400 miles wide and an inch deep. So we try to gather a lot of different information from a lot of the experts that are actually really super in depth to the topics and the issues, gather that literature. So we kind of have a little bit of a foundation which to build our knowledge base as well. And then we did cross tabulations of survey data. I'm going to talk about that next slide. And then we also interviewed some rural EMS agencies across the state of varying sizes, just to kind of get an understanding, put some meat on the bones. But in reality, this was mostly a data-driven project. And most of the data was taken actually from the 2016 Rural EMS Sustainability Survey from the Minnesota Department of Health, who just did a fantastic job. They sent out a survey to all agencies outside of the 7-county metro, EMS agencies, and asked a series of questions. And those sections were characteristics of the agency in which they were representing, the workforce and staffing issues, agency leadership and financial management, medical direction of the agency, and then community relations. There was, I forget how many questions there were, but there were quite a few. And they summarized this information. What we did a little bit differently is we got those responses from the Minnesota Department of Health. So the raw data, and in case anybody's worried, they did take out any identifying attributes of the responses. So we weren't able to track any of the responses to a specific agency or anything like that. But we did some crosstab analysis. So instead of, things like, let's say 62% of agencies outside of 7-county metro have a formally trained manager leading their agency, we wanted to see if there were significant differences in responses based on what size their agency was. That could lead to a little bit different of kind of policy solutions and ideas. And so that's what we did. And so we did a whole bunch of analysis on crosstabs on the responses. And just to note, all relationships provided that I'm going to give in these presentations are statistically significant with p-values less than 0.05. So let's talk about today's journey. We're going to talk a little bit of context, so get a little bit of history, and then talk about revenue and sustainability of rural EMS. Why are we in the situation that we're kind of in? We're going to talk about the 3 key themes that came from the research, which was professional management, sustainability, growing the pool via collaborations and consolidations, and a nuanced approach for transforming EMS. And we'll dive into that a little bit more here. And don't worry, this looks long, but each section is just a few slides. And then we'll have some recommendations at the end as well. So I did want to say, before I launch into this, I'm sure some of you are going to have some questions. Feel free, we have a Q&A. I don't know what you'd call it, like viewer in Zoom here. And also feel free to use a chat, whatever you're most comfortable with. We're going to hold off on answering any questions until we get to the panelist discussion. And then we're going to start really kind of diving into those questions. We have a set of questions for the panelists to answer, as well as engagement from you guys. So we'll kind of dive into that a little bit more, but please feel free to start putting those questions in. Both my colleagues, Marnie and Whitney, are monitoring both of those to kind of start collating and gathering and figuring out what the main core questions are, and they'll pass them along to me. So let's talk a little bit about history real quick. I know it doesn't sound interesting, but actually it's kind of it when we're talking about EMS. This is just like a real quick overview of some highlights. So really EMS comes from wartime. In particular in America, is tracked to the Civil War for essentially transporting injured soldiers. That's really kind of the basis of where EMS started, particularly in America. And right after the Civil War is when you first started seeing kind of ambulance services and types of EMS actually be developed in communities for community help. 1920s, we had the American Red Cross started to develop trainings around this that kind of opened it up to the general public. Further advancements due to World War II in the 1930s. And then 1960s and 70s is really when things took off. So up until the 60s and 70s, largely kind of, let's talk about ambulance services, was largely for transportation of patients from a place to another place. Actually, before the 60s and 70s, a lot of ambulances were run by the funeral homes because they had hearses. Essentially, they had vehicles that would haul injured people around. And so they were largely the ones to run it. But come the 1960s and 1970s, the federal government decided, no, we need to make some major inroads in both cardiac arrest and as well as injuries during car accidents. These were looked at as major public health issues that the federal government decided to put major investments in. And really everything stems from those investments that happened during the 1960s and 1970s. Interestingly, a lot of the funding and a lot of the structure that was built around our current modern day EMS was through the Department of Transportation. Again, looking at EMS not necessarily as a healthcare institution, but as a transportation institution, which is kind of interesting. Then in the 1980s, essentially the federal government has withdrawn support and hasn't done, I would say, a significant amount since. It's given out grants. There's been some studies and things like that, but as far as like laying down further guidance and restructuring, little has been done. And so that's kind of where we're left at today. And in Minnesota, that's the framework that we developed during the 70s and 80s, and that's what we're left with today. But it's not like we don't know what the next step is. There's plenty of research and plenty of agreement amongst EMS professionals about where we need to go. And that's really going from a transportation service to a healthcare service. And so really that means being less reactive and being more proactive. So for example, having ambulance services be isolated from other health services, how do we integrate it with the healthcare system? Reacts to acute illness and injury versus acts to promote community health. Finance to service to individuals versus funded for service to the community. And that finance to service to individuals is a really key one, right? We'll talk about that in just a second, but this is really the trajectory in which we want EMS to go into next and where EMS wants to go as well. So further on the context, then the revenue and sustainability of EMS. Now I know most EMS people involved in their local agencies or run them are probably being like, yeah, I know all of this. But there are legislators that don't, and a lot of decision makers that don't as well. I'm on city council here in New London. We own our own ambulance EMS agency here in New London. And going through this, I was rather surprised to find out some of this stuff. So that's why I feel like it's important to relay the information. So one of the contexts that we look at in terms of essential service versus transportation service is we expect our ambulances to be 24-hour ready. So to have an ambulance or a primary service area license, you have to be 24-hour ready. You have to be able to have someone answer that phone call, a truck ready to go and make that call 24 hours a day, 7 days a week, holidays and everything. So that's, again, expecting it to be an essential service. They cannot reject service based on ability to pay. And for the most part, are mostly professionally trained. This is very similar to fire departments and law enforcement, which are considered essential services by the federal government. Currently, EMS is not. It is not considered an essential service, yet we have rules in place that makes them operate as if they are an essential service. Where things get weird is that we pay them as if they're a transportation service. So ambulances typically get reimbursed if only transporting a patient. That's starting to loosen up. That was real bad in the 80s and 90s. That's starting to loosen up now, where if services are provided, sometimes an ambulance can be reimbursed, but it's still kind of a sticky subject, and it's pretty difficult. And reimbursement rates are low. So essentially what we have here is what we call the rural nemesis, economies of scale. We have high overhead because they have to be ready. An ambulance costs the same for a smaller town than a larger town for the most part. Staffing is going to cost the same, maybe depending on your mix of volunteer and paid staff. Your overhead is going to be pretty high, but yet your call volume is where you see the major differences in terms of smaller rural agencies versus maybe large metropolitan agencies. And they can't meet the economies of scale in order to be sustainable. Again, the rural nemesis. We see this in basically every research that we do. And it's also a challenging environment to have an EMS in rural areas. So larger geographic spaces with fewer people in it, higher percentage of people on fixed incomes, which also leads to a higher percentage of people on Medicare or Medicaid. And those typically aren't great for reimbursement rates to our agencies. And we also have a higher percentage of people with high deductibles. So with the Affordable Care Act, a lot of folks got health insurance, which has been great. But one of the other things is that since the deductibles that people can afford, or the plans that people can afford typically have really high deductibles, sometimes that ambulance service, which comes in a bill, won't be covered. And it's the purchaser of the plan that has to cover that. And that could be quite a bit of money for somebody that, you know, is on that type of plan to begin with, probably because they don't have a lot of money. And so then it's up to the ambulance agency to try and track them down, get the bill paid and things like that. So there's all kinds of reasons why that's a bit challenging. So this causes all kinds of issues when we're talking about EMS in rural areas. So a higher reliance on volunteers, less likely to have a professionally trained manager, staff volunteer recruitment and retention issues all over the place, more likely to offer basic life service versus advanced life support. These are all kinds of things that when you read about rural EMS, these are typically the things that come up and are typically some of the things we see in rural Minnesota as well. So that's really the context. And what this might lead anybody that's looking at this stuff and thinking about it is like, wow, we just need to give them more funding. We need to increase their reimbursement rates. We need to give them more money. We need to spread that cost around the community. And absolutely, I think any EMS agency or any leader is going to be saying, yeah, make it rain, right? Like we will take the financial support. But there are some key things that we should probably prioritize if we really want EMS to take that next step. Just throwing a bunch of money at the issues won't solve some of these core problems. As we kind of continue to go down this road and think about future investments, which needs to happen, there are three themes that we kind of came up with looking at the data in particular, and then having the interviews and looking at the academic literature. Is one, agencies need support to be professionally managed. We'll talk about that a little bit more. Agencies need to be supported to find ways for collaboration and or consolidation. I hate saying that word, particularly around rural areas, but it's something that needs to be discussed. And we also need to have a nuanced approach to developing policies and support systems. Really, we can't have a one-size approach to policy or performance standards. So we're going to dive into these one at a time. So let's talk about professional management sustainability. And I just want to start off by saying this is not a criticism of management, that they're poorly managed or anything like that. This is more about, are our agencies supported in a way that they could take advantage of all the opportunities that are in front of them? Can we really expect a volunteer that doesn't have training in some of these topics? Can we really expect them to do the job? And that's a bit unfair. So when the Minnesota Department of Health, they put out their survey results, it's somewhere around, it was over half of agencies outside of the 7-county metro had management or their agency director or manager that was professionally trained, either in leadership or business or nonprofit kind of training. But when you broke that down by the size of the population the agency was serving, it was pretty statistically significant difference. So as you can see, an agency that served a population 15,000 or greater, almost 100% of their managers had been formally trained. And as you get down to less than 2,500, so our most rural agencies, it was 38% of those agencies. And again, this was pretty significant. And so it reduces quite a bit. During interviews, some of the main things that we heard was, we asked the question like, how do you think having a trained manager running the agency is a benefit? How big of a need is that in rural EMS? And some of the quotes coming down was, it's huge. Agencies need the right person with the correct skills to lead. Management of any size agency is going to need more than just someone to just volunteer their time. There's still plenty of agencies in our state where the person managing it is the person that happened to just raise their hand at the meeting, right? It's not that they had the skill set to be able to do it. It's that they may have at least had time to do it, or at least willing to do it. And as EMS grows in complexity, which some of these quotes say, is that really the right thing? So we need to have trained managers. Training them is absolutely necessary. The role has grown significantly in complexity. There needs to be someone that understands EMS, the financial pieces, the regulatory pieces, and how to handle staffing. Just to kind of give you like an idea of the complexity of running these agencies now. So we're talking about licensing regulations, staff training requirements, navigating the philanthropic ecosystem, being able to write grants, organizing fundraisers, manage personnel, experience with healthcare services, and at the top of that, be able to provide medical services while they're on duty, right? Like, so this is a lot of stuff for one person to figure out and know. One example I'm going to give, I went into here in the report was looking at staff recruitment strategies. So if you look at the data that we were handed from the Minnesota Department of Health and any sort of academic literature that does any research on this, what you'll find is that staff recruitment or volunteer recruitment and retainment is a real challenge for rural EMS agencies. And there's been plenty of things written about, okay, what can we do? What kind of strategies can an agency implement in order to try and get over some of these challenges that they have? Some of them are identifying potential recruits by utilizing personal connections, integrated approach to training, such as collaborating with healthcare providers, creating a dedicated team within the agency to focus on recruitment, reducing barriers costs by the cost of training, raising visibility of the agency in the community, offering incentives to employers who allow their employees to respond, investing in pay and benefits, right? So there's a whole gamut, and that's just a smattering of strategies that are being discussed in the field and what agencies are being told to do in order to help some of these barriers. We call this like a staff recruitment plan. Do you have a staff recruitment and retention plan, or a volunteer recruitment and retention plan? Have you developed one? Are you implementing it? What we saw when we did crosstabs on the survey data, so here's a percent of agencies' response by whether they have a formally trained manager. So the dark red bars are agencies that have a trained manager, and the kind of more orange are agencies that do not have a trained manager. And as you can see, if the agency had a trained manager, they're more likely to have a staff recruitment plan, and they're also much more likely to have a staff or volunteer retention plan by quite a bit, again, statistically significant. While at the same time, they're significantly less likely to claim that recruitment is always difficult. So again, there's a little bit of what we would call correlation in terms of, right, if they have a manager, it might be a bigger agency as well. And that's absolutely true. There is correlation there. But when we ran the analysis, again, this still came out statistically significant, even for accounting for the size of the agency. So again, it's not like, oh, if we had managers, everything would be fine, but it's again, another piece of the puzzle in terms of trying to make us a little bit more sustainable in taking that next step, evolutionary step in EMS. So growing the pool via collaborations and consolidations, this one's a tough one. What we're talking about here is how can we move from kind of a more siloed type of structure that we have in EMS, where a primary service area has their licensed ambulance and they very much operate within that area. There's not a whole lot of sharing or going outside of that area to collaborate or to coordinate or anything like that. This coordination does happen, but again, the operations and the resources can be pretty siloed off, and from what we've seen in the data and from what we heard from interviews. What we want to get is, can we somehow utilize this to get to this? And this is just an example, right? Can we pool together the call volume or the population of the public service areas so that these ambulance services could then afford, let's say, a manager? And this is Microsoft PowerPoint's icon for manager, by the way. If you're wondering what that is, and I know most EMS managers are probably laughing because they probably don't wear suits or anything like that, but that's kind of what this is trying to show, is like, can we do types of things like this? How do we do it? There's a lot of literature written on the benefits of collaboration and consolidation. They're more likely to offer advanced life support, more likely to pay staff, more likely to afford more staff, and more likely to have access to equipment that wouldn't otherwise be affordable if you were just kind of serving your small call volume and being rather small and siloed off. In Minnesota, we actually have a really nice framework. So we have the 8 EMSRB program regions of the state, and then we have a little more than 250 ambulance service areas, or primary service areas across the state. And believe it or not, when you look across the country, this is actually considered to be a really good system. In the interview statements, it was interesting. It says, it's becoming clear that we have too many small EMS agencies to sustain them all as individual operations. Where did I find agencies of varying sizes can share trainings, rigs, budgets, and even staffing? It doesn't have to be consolidation. For example, finding ways to support us to form consortiums would have a lot of benefits, right? So we don't have to like smash agencies and form one big primary service area, but how can we break down some of the barriers and support our agencies to do more of that work? In the data, I used a proxy because the 2016 survey didn't ask specifically how much do you coordinate or consolidate or collaborate with neighboring agencies to solve your problems. But one question that was asked was, are you owned, managed, or have a relationship with a corporate healthcare system in Minnesota? And so we kind of use that as a proxy, just with the understanding that if an ambulance is owned or managed by a corporate healthcare system, they likely have more of like ability to shift resources, consolidate or coordinate staff. And there's just access to more things, right? You're a part of a larger system. You kind of grew your pool of resources of people. And so when we looked at that, so this light blue is no relationship with corporate health system, and then the kind of darker blue is a relationship with a corporate health system. Again, this is just a proxy. You can see there was pretty significant differences. Again, have trained managers more likely if they had a relationship with corporate health system. Always difficult to recruit staff was significantly less likely. More likely that they had a retention strategy, and more likely to offer full-time advanced life support. These again, just kind of shows that there's some promise here, right? This isn't the silver bullet in answering all of our problems or questions, but it's another kind of piece of the puzzle, and that we need to explore as a state. So what's stopping this strategy? It's an interesting question. So when we asked that question, because there was no data to say like, all right, why aren't we doing this more? And on the ground, there isn't what we would call like significant necessarily policy barriers in the way, but there also aren't any policy incentives to do it. And some of the things that were getting in the way is just how integrated a lot of our EMS and ambulance services are kind of like linked in and interwoven into community, right? So during the 60s and 70s, our community started these ambulances. And as people would say, like, they're at our football games and it has a town name on it. They're supplying health service, that they're supplying health services at our high school games. They're our neighbors, they're our friends, they're our fathers. You know, there's all this kind of really deep rooted history in a lot of this. And that can be hard to untangle. At the same time, you know, who's going to say if two adjacent primary service area ambulances are next to each other, only one can hold the license, right? Well, who wants to say like, yeah, I guess you can hold a license, but we're somehow collaborating? Is that a collaboration, right? So you kind of run into these weird issues about, you know, having that pride and that history in terms of being able to offer that in your community. And then there's also just flat out geographic differences. There are places in our most rural areas of the state where, you know, having collaboration means really small agencies being next to each other collaborating. Is that really enough? Because there is no larger healthcare system nearby. There isn't a larger community nearby that has a EMS agency that could then help grow the pool for some of the surrounding smaller ones, right? So it can be a little bit of, you know, is it the right place and the right time for folks as well? So this is the last theme, and then we'll head into the panel. And I know we're getting some questions, so we'll get to that in just a second. I want to talk about a nuanced approach for transforming EMS. So, you know, some of the quotes I heard was, we don't need to burn anything. We don't need to totally just deconstruct what we have built here. Many areas of the country are actually trying to emulate Minnesota's framework. And that's kind of what I was saying with the 8 EMSRB regions, as well as the primary service areas, is actually something a lot of other states are trying to emulate, because it's a pretty well-run, highly coordinated type of framework. I mean, there are still states where you have ambulance chases, right? Where you have two opposing ambulances trying to get to the same scene at the same time, high-speed traffic, because they're competing against each other. That's not exactly a great system either. We need to be thoughtful in how we move forward. It might be that an all volunteer run agency is the most appropriate structure for some areas. And there's likely a threshold in call volume for which we can't rely on volunteers. And I'll talk about that here in just a second. So I think when anybody thinks about rural EMS and how do we support and fund them, they're probably thinking in terms of, we got to figure out a way to help fund our tiniest, most rural agencies in the state, because they're probably have the most severe issues. It could be, in some ways that's true, but in other ways that may not be true. I'm going to provide an example here. So this is again from that 2016 survey, percent of agencies that find it difficult to recruit staff by size of population served. And what we would expect is that this kind of less than 2,500 would have the highest percentage of their agencies. Again, this was statistically significant. And you'd kind of see more of like all the way down. This would be the highest, next highest, blah, 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 so on and so forth. But what we saw is actually pretty high numbers in this 2,500 to 5,000, pretty significant actually. About 77% of agencies that serve that size population say, yeah, it's difficult to recruit staff by size of population. But maybe it's not that surprising, right? So when we looked then at the question of what are some of the barriers to staff recruitment, what was interesting, and again, this is by population, the size of the population served, right? So this lightest is kind of agencies that are serving less than 2,500, 2,500 to 5,000, and then the 5,000 to 10,000, 10,000 to 15,000, and 15,000 or greater. What we saw is when inadequate pay or time availability were presented as barriers to staff recruitment, it was significantly higher in those kinds of size populations, not necessarily our most rural. And so what this kind of tells us is that it's likely that we have a lot of agencies where they have a high enough call volume where volunteer burnout is a real thing, but the call volume isn't high enough to actually pay staff, right? And so that kind of presents a very different kind of policy solution, policy discussion, whereas inadequate pay, maybe a lot of those real small agencies are like, you know, we don't need to pay our staff because we don't really have that high of a call volume, but training is something. And that's this next slide, which is the percent of agencies that the amount of time to train is a barrier to staff recruitment by size of population. Again, those are highest amongst our lowest, our agencies serving the lowest population. So that kind of changes this kind of conversation about, all right, we can't just fund the smallest rural areas so they can pay their staff. That actually might be more appropriate for some of those where they're in that threshold where they're high enough, burning out their volunteers, not high enough to pay. While at the same time, can we do something around training for our smallest and most rural agencies? That's kind of why we talk about that nuanced approach. So what does this have to do with policy? Well, as we say, be thoughtful, be nuanced, and kind of ripping off something we typically say, you know, if you've been to one small town, you've been to one small town. So this is very similar. If you've seen one rural EMS agency, you've seen one rural EMS agency, right? It doesn't represent all rural EMS agencies. So recommendations real quick. The Office of Legislative Auditor did release their audit a couple months ago now. And I know it caused a pretty big wave in the EMS community regarding some of the recommendations. A lot of them, I think, pertain to what we've talked about today. So the legislature should retain primary service areas for ambulance services. Again, as we said, that's a pretty good framework and a good structure, but it should restructure how they are created, modified, and overseen. And I think that kind of gets into this idea of like, well, how do we incentivize them collaborating where appropriate, maybe consolidate? How do we kind of break down some of those barriers and incentivize that to happen? The legislature should adopt more stringent statutory requirements for renewal of ambulance service licenses. The legislature should direct EMSRB to develop and enforce performance standards for ambulance services. This one, I think, can make us shiver a little bit. And again, I think it goes back to being more nuanced in our approach. Having a one-size-fits-all set of performance standards across the state, I think, is going to be very, very challenging and could do more harm than good. Typically, when we've seen that happen in Minnesota or even in the country, good intentions can sometimes lead to bad results. And so be very wary of moving forward on anything like that. And one of the toughest nuts to crack is like, well, what should the expectations be? As a rural person, should I expect the same performance standards as if I live in the Twin Cities? That's a tough question to answer. And is it even possible? The legislature should explore options for improving ambulance service sustainability in Minnesota, potentially through pilot programs, absolutely. And the MSL board, these last two are more directions towards the MSRB board and how they're structured. Not as relevant to our research here, but my last slide here, and then we'll get into panels and questions. The primary service area framework established by Minnesota was appropriate for its time. Recommendation to consider is, how might we provide incentives for neighboring EMS agencies to start discussing collaboration and consolidations? And we're going to talk about that a little bit more with our panelists on what could that look like? Because it's kind of a vague recommendation, but it could go in a lot of different ways. Provide resources that help ensure all agencies are professionally managed and trained. Conduct research on the threshold of call volumes versus full-time staff. That was kind of getting into like, we have this area where the call volumes are high enough to burn out volunteers, but not high enough to pay them. What is that threshold? And then how do we fill that gap? That will be an important piece of research moving forward. Make sure we're creating eligibility requirements for providing support to an agency using multiple variables. So it's not just about call volume or just how rural something is, but taking into a lot of different variables to try and find the best policy solution. And again, do not develop a one-size-fits-all set of performance standards. All right, I'm gonna going. We have Mark Jones, who's the Executive Director of the Minnesota Rural Health Association, and Jenson, the Executive Director of the Southwest Minnesota Regional EMS Program, and Gordon Vosberg, who's the Senior Director at CentraCare for EMS. And I had interviewed all of these folks during the research, and I really had a great conversations with them. I'm hoping they can help put some more meat on these bones that I kind of laid out here. I got to pull up my question, but first of all, thank you everyone for joining. I know we do have some questions here, so I'm going to ask a question that we already have scripted so I can kind of go back and look at what's being sent to me here. And we're actually going to start with you, Anne. I know when I talked to you, you talked a lot about some of the complexities that EMS agencies have to abide by, and some of them just running an agency, what that complexity looks like. And that really has changed in your mind over the past maybe 20, 30 years, where you just see it kind of getting increasingly complex. Can you give us just a little bit of grounding on what that looks like in your eyes? What are those complexities?
It used to be ambulances were never as busy as they are now, first of all, and we could rely on volunteers. We didn't have the volume. And we didn't have the expense to run an ambulance. Now, the rigs are expensive, the equipment's expensive, the insurance is expensive. So everything's just more. And to keep these rural ambulances staffed, and, part of it too is letting people leave their jobs. Do employers want to let these volunteers leave and come back? Are they paying them for that missed time? Are they not getting paid for that missed time? Do they have to make it up when they get back? It's just gotten to be more of a business now. For as much as I love volunteer ambulance, we are going to have to start to look at this, I think, in a little bit of a different way to keep these ambulances open.
And I guess for the group, I know one of the things that came through with the data, and one of the recommendations we had, is how do we support our agencies to be able to afford and be managed by someone that is probably a little bit more deeper trained in all these different types of issues. I guess I'll throw it to Mark. Do you feel like, yes, that's true, and two, is that possible?
So yes, I do believe it's true. So I think ambulance management starts with an investment. So that's the first step, is investing in management, investing in the time for someone to put in to manage that ambulance. Anne talked about just the demand that's on these people. So just looking at it from a management standpoint, if there isn't a person who has the time and is responsible and is given the resources to recruit people, to support the staff, to maintain the fleet, to order supplies, to do all of the work, the performance improvement, even the outreach with the local government and the local healthcare system. If there's not someone who has time, if managing an ambulance service is something you do in the evenings,
I think we lost Mark.
I think we may have.
For the audience, it's kind of funny. Before, Mark likes to talk, and this might have been internet's way to say Mark's done.
Yeah, it is. So yeah, so I do think it's possible, but it's got. I'm sorry about that. Rural broadband. Let's all pull for rural broadband. So I do think it's possible. The investment needs to be in the time. There needs to be time for the people who are managing services to manage the services. When you get into the larger services, it's still the same. Managers need to be afforded the ability to know what's happening, know what's on the cutting edge, to further their educations. I mean, when we look at business, any other business, developing as a manager is ongoing. It's a life's journey to develop as a leader and a manager, and we need to invest that time to do it. Someone who's trying to manage an ambulance service after work or on the weekends, putting agendas for meetings together at 10 o'clock the night before the meeting, it makes it difficult, and just need more time.
Now, I know Gordon, kind of going over to you at CentraCare. So you guys have 6 ambulance services that you manage under the kind of umbrella of CentraCare, correct?
Correct, yes. So, and that's just a recent change within the last 2 years. What we found is we needed to build some economy to scale. So just real briefly, while my internet holds up, we had 6 ambulance services. They were operating independently. They were all departments of hospitals, 5 of those hospitals being critical access. So they had their separate budgets. The ambulance managers, they all reported to different hospital administrators and leadership. We really did not have very good economy of scale. 2 of our services had pretty decent run volumes, and then the other 4 were lower volume services. So staffing and purchasing and everything, that became a real struggle for those for the group. So about 2.5 years ago now, we undertook a project. So CentraCare EMS is now a system level EMS department. And what that's done, that's brought a tremendous amount of economy to scale and collaboration. We have a single organizational structure. Each of the 6 regions has a manager that's responsible for that region, which goes directly back to what Mark had stated. And that's allowed us, all of our staff orientation is the same. We can recruit as a group. All of our budgeting is the same. So purchasing supplies, you have more economy to scale there. Instead of purchasing 1 ambulance, you can buy 2 or 3 at a time or 4 at a time, and hopefully, see some savings there. Training was another big thing, and having a uniform set of medical guidelines. For instance, now we're able to send all of our staff through our SIM center for annual training, so that every single EMT and medic is trained the same way throughout our system. So those are some of the system pieces that have really come together. The other system piece is that we had 6 different dispatch centers. Those 6 dispatch centers did a great job. I can't say enough good things about them, but for us to control our daily operations, that became really eclectic and really difficult. So now we're down to 2 dispatch centers, and we're able to, again, that economy to scale, we're able to control things more. And then we're able to have our 2 larger primary service areas support those lower PS primary service area services, so we can bring all of this to them. We also use community paramedics in a couple of our small services, so that they'll be in a jump car doing community paramedic work. And if a run comes in, they're able to hop on the ambulance and provide advanced life support for those services. Even with all of the integration, though, there's still some really important local pieces that I don't think anyone wants to lose. The community-based collaboration with your other public safety partners, police and fire, that's critical. The community involvement, we did a toy drive last year, each of the regions and donated those toys for Christmas. The football games, all of those pieces. And then of course the 911 operations and the staffing, those all remain down at that individual regional level. So I'll give the floor back now. I think I talked more than Mark, I'm sorry.
Well, actually, we did have a question that I think I would like some more information back. I think there's this fear when we talk about consolidation, and maybe that is probably not the perfect word for what we're talking about, but it is this idea of like, can we centralize some things? Can we grow our pool in certain ways that these agencies can be much more sustainable as individual agencies? But one of the things that got brought up is, from CentraCare's perspective, as you kind of took on responsibilities of these ambulance services, was there ever the thought of taking an ambulance away from an area, or managing it in a certain way? The fear was that call times would increase because it was being more centrally managed and not locally managed. Do you have a response to that?
Yeah, I do. So the big thing is we wanted to maintain the response time quality and the quality of service. That's key. And I think maybe instead of consolidation, collaboration might be a better term, because that's really what it is. So with that collaboration piece, each of those ambulance services were serving a specific community, and geographically they were far enough apart that any type of additional consolidation really didn't make sense in our current situation. The other thing that we would do, though, is we've been trying to make ourselves available from if services are having staffing problems and stuff, can we, being a good neighbor and trying to help them out. And I think that's something Mark and I have talked about in the past too, is how can we be good neighbors? So hopefully that answers the question.
Sure. Well, yeah. And Ann, I want to throw this over to you. We talk a lot about, CentraCare, a pretty large healthcare system, has a willingness to take on these ambulances for reasons that are beneficial, I'm supposing, because it integrates well within their continuum of care, and it just makes a lot of sense for them financially. But in Southwest, there are regions, and in Northwest Minnesota, there are regions where you don't have a large healthcare institution that might be able to take this on. So collaboration and consolidation of different aspects of these agencies may look differently. Is it still possible out there, do you feel, or do you feel like they're just, some of these places are too small and rural that, it's just going to look differently? What are your thoughts?
It's very possible here. We do have like 3 hospitals out here. I think 3 small rural health hospitals, and they share a surgeon, they share ultrasound equipment, they share, and so, the idea there is a lot of my little services are just 12, 16 miles apart. So if you hire a manager to manage all 3, and maybe some of those people work in those other towns, so you can share them for call when they're in those other towns, working during the day and back in their town at night. So I don't like to use the word consolidate either. I like collaborate. I really think that if we can collaborate our services and our equipment, it is possible here. I do believe that, yes.
And correct me if I'm wrong, Mark, you might know this better than me, but there are places where, maybe into northern Minnesota, where there are consortiums currently to share a medical direction. Is that correct?
Right. Yeah. So there are areas that Ann's region has shared medical director services. So there are already areas where resources are being shared, and I think there's great opportunity to look at what other resources could be shared to try to minimize some of the struggles that we have and create those efficiencies.
So we're having a really robust discussion in the chat window, and I want to get to some of these questions because I think they're really interesting. This first one, it's going to go back to you, Gordon, talking about how might community paramedics and the expansion of that play a role in the sustainability of local programs. And I know, Gordon, you kind of have an interesting story of CentraCare and how you actually utilize community paramedics to offer part-time advanced life support. Is that correct? Yes.
So I think that in lower call volume primary service areas, it boils down to doing whatever you can to help improve the economy to scale. So for us, in the 2 PSAs right now that we're using them, it made sense. The community paramedic was able to help keep people healthier in those communities with their community paramedic visits. They were able to keep people's healthcare costs down, which are really and align them with resources. which are really the big three things that community paramedics do really well. So when you look at that in some of these, in these two particular PSAs, you would have two ambulance runs a day. So from an economy standpoint, it's really difficult to staff, ALS paramedics. So by putting the community paramedic into that model and putting them in a jump car, giving them the defibrillator and a first in bag with the medications and stuff, they could dual respond with the ambulance and help keep the people in those communities healthier and provide some economy to scale. I think it's very doable in areas.
One other question, and I will actually throw this one to Mark. There's some conversation around, both in this chat and while people were reviewing the report before we released it, is it time to really reconsider volunteers in general? Can we honestly expect to sustain our agencies through volunteers, or do we just need to get to a place where we're funding every single agency in a way that there's paid staff, full-time, part-time, or whatever that might look like? And how then does the community pay for that? Now, I know, Mark, it was written in our report, there's the state legislature did open it up and raise the cap in which a special taxing district can raise the cap in which they can levy their districts on property taxes that can go to a EMS or an ambulance agency to help pay for some of these costs. But that's a tough sell. What are your thoughts? That kind of question of, if we have to get away from volunteers, go towards paying, question two, then how do we pay for that?
So I don't know if we need to completely go away from volunteer labor completely. There may be a place for it. However, there's also a place where we do need to go away from it, and it's difficult to consider sustainability when we rely on the same model that back in 2002, the Department of Health had a report that said workforce was going to be a challenge and we can no longer rely on volunteer labor. So that was 20 years ago. And so the action has to be taken. Can volunteers serve? And yes, they can. But can we rely on them as the main labor force? I don't think so. And I'm going to say absolutely not. And I'm also going to, let's maybe go away from the word volunteer. Volunteers can actually, as long as they don't rely on it as their income, they can be compensated. So how do we pay for it? That's going to be something that has to be figured out locally. I don't think that there's a broad sweeping brush that can just fix all of the wages and put them where they are. It's not only our EMS, our small ambulance services being able to pay for staff. It's also our bigger ambulance services and trying to pay for paramedics, and Gordy trying to staff community paramedics. And so I think we need to get away from the reliance on volunteers as the staffing model. And I think we need to get, also my personal opinion, we need to change the conversation from someone else subsidizing our ambulance service. If you take into consideration the volunteer labor, it's millions of dollars a year that the staff who don't collect a paycheck give to the ambulance service. And I just have to ask, why is it the staff that are supporting the ambulance service financially? And then you look at businesses that let their people go. Well, let's walk down Main Street in Minnesota. There's less businesses. There's less people working at businesses. Every business has gotten leaner, and they're doing the same amount of work with less people. So there's less people that can leave their job. And when they do leave their job, those employers lose productivity. So once again, someone else is subsidizing that ambulance service. And does it have to go to a special taxing district? I'd say it can go to a special taxing district. None of us want to pay more taxes, but it's difficult to continue to put the financial burden of supporting an ambulance service on the back of the people who work for the ambulance service.
So Ann, I know you've actually had some conversations, I think with county commissioners about the potential of that, or have at least kind of thought about it in your head. What are some of the comments you're getting back about that idea, or from any other agency that's thought about this? What are the comments you're getting back from county commissioners about doing something like this?
Well, they don't think they should have to carry it either. You know, the few that I've talked to are not in high favor of having to do that either. It shouldn't have to come back to the counties. You know, their feel is that the state pushes everything down. So I think a taxing district might be a hard thing to sell in some of my rural communities out here.
Not to put you on the spot, Ann, but I thought this was an interesting anecdote that you told me. I think it was in Dawson, and it regarded how much I think the surrounding townships were paying the fire department versus the EMS service. Can you provide that example? Because I think it gives some context in this idea of like, why aren't we considering EMS to be an essential service? Why aren't we all paying for it? I remember one EMS manager was like, look, this isn't just about the people that live here. We have people that don't live here that drive through here that need our service, right? So it should be funded on a larger scale. Can you kind of provide that story?
Sure, I can, because it was actually between me and my father, who was a town board member. And so when I got on the Dawson ambulance 26 years ago, meeting, and I said to him, well, how much do you pay those firemen? What is their yearly draw to them? And he said, well, about $3,000 a year. Well, that's funny, because the ambulance we have since fixed that. I mean, we've narrowed the margin, but yeah, the support, there is a difference.
Right, and you cut out there a little bit, but I think it was $3,000 for the fire department, and they were providing, was it $600 to the ambulance service? So
to the ambulance, yep.
Yeah, so pretty significant difference in terms of mentality too, and just how we've always looked at EMS being a transportation service, not really an essential healthcare service. And I think that kind of gives us a little bit of idea of some of the mentality behind some of our county commissioners and township boards.
And I agree with Gordy. We need the fire department. We need our law enforcement. I mean, we are a team out there.
Yeah.
And especially as our services get smaller, especially daytime coverage, you know, we depend on law enforcement to come and help lift and move those patients. And as our patients get bigger, sometimes we rely on the fire department to come and help lift. So we are a team, and we need each other. So we just have to figure out how we can make this work.
Right. Gordy, we're getting a few questions. I think people are kind of curious about the model you guys are using at CentraCare. I'm going to throw a couple at you. Feel free to say, no, I'm not comfortable answering that because it might get a little too much into your financial stuff. But this one person, Riley, asked, how much does CentraCare spend on their ambulance and air helicopter pad support each year, excluding the donated labor?
So now, are they speaking to the helipad support, or are they speaking to overall? So I think the operating budget, I'm going to respectfully decline to answer, just because I think that gets a little too deep into operations. I can say though that it is a significant amount of money when you compare it to our net income at the end of the year. I think that's a safe way to probably state that. Like most services, we collect, anywhere from about 37 to about 42, 43 cents on the dollar. So maybe hopefully that kind of answers the question for them without getting into proprietary data.
We also have one from Chuck Richard. Is CentraCare using a computer-aided dispatch?
Yes, we are. And that's one of the big advantages of combining into into the two dispatch centers. And that's particularly helpful, during at the height of the Omicron variant and each of the COVID waves, being able to see all of the ambulances on that CAD system really helped us coordinate non-emergency interfacility transfers. You know, if the truck for Redwood Falls was driving through Wilmer and there was a non-emergency transfer, we could put that truck on it, which benefited the patient and the, and also the hospital, which was tight on beds. So very, very helpful.
And a question I'm gonna throw out to the groups. I always love a quick data question, and I kind of know the answer to this. I know Amanda Anderson says, how many people working in rural EMS are volunteers in Minnesota? And I remember the Minnesota Department of Health survey. I remember like it's close to 80% of the agencies rely on a mix of either all volunteer or volunteer paid. I think the all volunteer, boy, I don't know. Mark, do you have any ideas?
I do not. I'm not aware of any. I'm not aware of it, that data being collected as to, when an EMT. I don't know how an EMT or a paramedic communicates their salary or what they make back to, through a licensing, or I don't think that is available.
Yeah, but I would predict quite a bit. Yeah, Gordon.
Yeah, Kelly, I just saw something pop up in the chat, and I think somebody weighed in on the cost to operate, and that's pretty close to what it costs to operate a truck per year. So if you have 10 trucks, multiply that dollar amount times 10.
Okay, yeah, thank you. There was another one here from Randall Fisher, which I think is kind of interesting. Just kind of talking about, the framework in which rural EMS is trying to function. Maybe rural health collaborate and create a state special taxing district for any county, city to participate in with their 911 ambulance service system to match state with local funds to ensure service in our small rural communities with less than 5,000 calls per year. Any thoughts on that? I'll turn it to Mark because you're kind of our policy guy.
Well, I think there's a lot of merit in that. That's, it's an idea. It's something I think that could be looked at. Anytime that we can utilize everybody's dollars, and we can come together, and what that would do is that would just grow the scale. I think that there's something to be said about that. I think it's a great option to look at as we really look at what is going to help us shore up and ensure sustainability in rural Minnesota. Thanks, Randy.
And what are your thoughts about trying to spread out just beyond your conversations with township boards and county commissioners? I know you guys started, or I forget who started, but it was the kind of cab that would help for mental health transportation and things like that. Can you provide a real brief summary of what that looked like and how you kind of had a lot of different groups kind of collaborate on that to make this roll?
Yeah, the county I live in, of course, mental health transports are big for everybody, mental health in itself. So we collaborated with actually the law enforcement, both the hospitals and the family service center. And we took a old squad car. So and it's got, it's equipped. And then we have a pool of people, first responders, EMS, and some nurses actually, and law enforcement that drive. And so we have like 46 people, I think, in our pool. And everybody threw in, I think it was like $2,500. And we don't get reimbursed for that transfer at all. We just pay the driver and the attendant. There's 2 that go on every transfer. And we use a texting system that texts out when there's a transfer going out of one of the hospitals. And it has really taken the pressure off the ambulance services because our pool is bigger. We have the vehicle, squared away for that use. And it just takes pressure off. Nobody has to really worry about a mental health transfer. It's just that everybody has to understand you're not getting paid for it.
Yep, right. And it's interesting how those types of conversations can roll forward, but sometimes these conversations around funding EMS somehow get stalled. And it might be one of those situations where it's always been there. You just expect it to be there. Why do I have to give it more? One question that came up here, I'm going to throw this one to Mark. Have there been discussions with legislators about state funding for EMS? What's being talked about?
There has been, and this year there were a few bills. There was a bill that was introduced to provide funding to just hire staff, to pay staff for smaller services. There's bills that have been introduced to put a ton of money into training. The Ambulance Association worked on a bill to provide scholarships for paramedic students. So, there is great conversation and there's great engagement at the legislature on ideas to invest in EMS, both metro and rural. So there is hope, but I think the OLA report and your report, Kelly, are really going to help to kind of focus all interested parties, legislators, the industry, organizations such as ours, with the Rural Health Association, on conversations that are really going to be long lasting and helpful, that bring everybody in, but allow the system to build itself back better, but start at that local level. So there have been many conversations and bills introduced to put funding toward EMS.
So here's an interesting question. It comes from Karen. Maybe an odd question, but it really isn't, Karen. A volunteer driver has to pay taxes like a 1099 once they make over $600 in reimbursements, if they are paid over 14 cents a mile. Do volunteer EMS drivers and workers have to watch that issue as well, or is it something different?
They're taxable wages.
Yeah.
They're earning a salary. So
Yep.
there's no tax benefit to being a volunteer.
So again, it could be one of those issues. And we actually wrote a report on the volunteer driver side of things for people that drive, particularly senior patients or people with disabilities to their medical appointments that get taxed like crazy after a certain, because they get reimbursed. If there's any federal Congress people or workers listening to this, might be something to look at, is trying to find some tax incentives to do things around that. One other thing, let's see. Well, we talked a little bit about the OLA report, and I did want to get your guys' response. There's been a little bit in the chat here talking about, it bringing up some good points. There's some good data there. And I know it caused quite a wave amongst a lot of kind of the EMS, ecosystem here in Minnesota. I would like each of you to kind of just talk briefly about, what do you think was, really worth hitting on in the OLA report? And was there anything that you're a little kind of nervous about as well? Because sometimes these reports can get drop like an anvil, and all of a sudden everybody wants to blow everything up. Gordon, actually, I'm going to start with you, kind of your thoughts on the OLA report and some of its recommendations. What's doable? What do you think we need to hold off on?
Sure. Thank you. Well, first, I mean, obviously a lot of research and thought went into that report. I'd like to focus on what I think we do really well in EMS in Minnesota at this present time. And you alluded to it in your slideshow presentation. And there are a lot of states that are really striving to have an EMS model that the state of Minnesota has. In particularly, one of my biggest concerns, and I think this is something that we really do well in Minnesota, is the primary service area portion of the operating statute 144E. That allows services of all sides with common borders to work together as long as they do a good job of servicing that license in their communities and those community citizens. It allows collaboration. When you look at system services, CentraCare is not a large ambulance service. We're surrounded in some areas by some rather large ambulance services, and we have great working relationships with them because of that primary service area law. We're able to collaborate. I think the training piece and the recruiting and staffing piece, that's going to become critical as we move forward. I can't say enough about the paid off-premise call staff that, and the volunteers that respond when someone needs, 911 assistance. We have to figure out a way to improve that model, whether they're paid staff or whatever. And then the education piece, how can we give everybody the educational opportunities to help improve the quality on those services? And then lastly is, and Mark alluded to this, the management piece is so important. If you can take 2 or 3 communities that are side by side, within close proximity, collaborate with one another, as Ann said, share those services, share a manager, help with all those training pieces and stuff. I really would like to see that focused on, as far as report findings and how do we improve some of those pieces for rural sustainability.
Yeah, thanks, Gordon. Ann, what were your thoughts?
I agree with actually everything that Gordy has said. And I think, we have some new leadership right now at the EMSRB. And I've been here for 8 years, and I think that we are really the best aligned that we've been in a long time with the people that they've brought in. And so I'm actually anxious to see what they can do. I mean, they've made some positive changes already, but I think the training and, getting some recognition and something more to our volunteers and just collaborating more and working more with the EMSRB. I think Gordy said it very well.
Yeah, thanks. And Mark.
Yeah, so I think the report from the Office of Legislative Auditor did a really good job of providing an understanding of our primary service area law. It's no secret that there's been a lot of conversation about the primary service area and conversation around competition and the lack of competition and the lack of local control. But what it really did from a rule perspective is it pointed out the theory behind the development of the primary service area, that it was the primary service areas were developed to ensure access. And when we talk rural health, it's all about access. So the primary service area, they're geographically defined, which good or bad, but it guarantees, and that's a guarantee, it assigns a geographic area to a licensee so that when you call 911, you hopefully can rest assured that somebody is going to respond. Now, when that ambulance is going to get to your side, it's going to differ from where you are in the state. But the primary service area law is so important for rural EMS. And if we look at it from what if an ambulance service decided that it's more beneficial for us to just do interfacility transfers out of our local hospital and respond here in town, so we don't have to respond 20 miles out there, taking an hour or 2 of our time. It'd be a lot easier if we just responded in town. So we're just going to roll back into town and somebody else can serve that area. Well, that's not easily done without finding someone else to replace that. And so I also agree that we need to look at the primary service area law. And there were some comments about populations changes and the review of the primary service areas. So if a population area starts to grow on the edge of one service, the neighboring service is growing out in that same direction and puts a substation out there, wouldn't it just make the most sense that a service 5 miles away in a population area responds versus a service 20 miles away? So to be able to have that function for the Emergency Medical Services Regulatory Board to do those reviews and to have a comprehensive review of primary service areas, bridges are put in, bridges are taken out, roads are put in, roads are taken out. So I don't think the primary service area, the boundaries need to stay so static. I think they can be reviewed, they can be moved and changed. And I think that much of the change in the rural areas is going to be agreeable. So that was my main takeaway. I appreciate that they identified the sustainability issues, that the reimbursement does not meet the cost of running an ambulance service. Gordy shared and I believe it was John Fox that shared the $500,000 to run a basic life support ambulance service. Well, if you do 350 calls a year and you're netting $500 for each run, you're at 175, 200,000. So you have a $300,000 gap if you try to staff that truck. That just doesn't work. There is no cost for readiness, or there is no payment for readiness. It's all service-based costs or reimbursement. So I really did appreciate the primary service area law conversation in the report and the sustainability.
And thanks for answering that. I think somebody did ask that question about, whether we need to redraw our primary service area boundaries. And kind of what you're saying is not only does it need to be redrawn now, but we should develop some sort of dynamic system where it's looked at more frequently than it's been over the past, since its existence, I assume. So I'm going to wrap it up with one last question. There were a lot of comments about training and staff. And I'm going to start with Ann on this one. A lot of comments about training just being too time consuming, too expensive, and too difficult to pass the licensure exams. Ann, is this something that you feel like a lot of your agencies in Southwest, they just struggle with? Like, one is trying to get somebody to agree to do this, and then two, to get them to even pass it is darn near impossible.
Yeah, I mean, it's gone from like 80 hours to 160, and we're asking volunteers again to do that. The regional programs now we have money for now to help pay for that, so we can link that bridge. And then it's the continuing ed. And even though I don't know how many years ago, Gordy, you can maybe help me with that, they dropped the number of hours that you had to have when they went with the National Registry. So that helps some. Yeah. But I see, like Dylan put in the chat too, that, retention, 46% of the people from 18 to 21 who let their license go were under the age of 30. So, and I mean, when I get to services, a lot of their people that they have are between the ages of 50 and 65 or 70 yet. So we need to somehow figure out how we're going to get that younger group involved and stay involved. And we talk a lot about going into the high schools and offering classes, which I think is a great idea. Working with the community college, I know people that took the class in high school and worked through college as an EMT, and which helps those communities too. They'd help our community when they'd come home. They'd be at that community at school. But it is a lot when you talk about a volunteer that this is not their career, 160 hours. And then it's not like you just get out of class and you can jump on, whoever you are going to be employed with. They also want, I'm sure, what I read is 3 to 6 months of ride along time as well. So it's a lot.
Gordon, I know you guys have done a lot of training in-house at CentraCare and then kind of sharing those resources across the board, but I assume, you still have to have folks that can pass those exams and take the time and pay for it and all that. Do you have any comment on it?
Well, I think just as Ann said, it's becoming increasingly difficult. We do have some paid off-premise call staff in some of our regions. And one of the things that we've done to try to improve recruitment is we do pay those folks minimum wage, but even with that, it's still really difficult because of that training commitment. And, and thank you to all these businesses that, in these local communities, the hardware store, the insurance agency, whomever, that, are good enough, are good community system, community collaborating folks that will let their worker go to do an ambulance run and help their communities. It is difficult. We're fortunate we have a sim center, which helps with our training, but it's still training that initial EMT and paramedic. I think that's the difficult piece in the rural areas. And I think that's something that all of rural EMS is struggling with. And I think one of the things, and Dylan can correct me if I make an incorrect statement here, but I believe the EMSRB and Dylan's team are really starting to look at a lot of these things and, you know, what can be done. And I think there's been some real positive conversations in amongst his team. So, but it's definitely a problem for everyone.
And for Mark, I guess, you know, part of that tension, I assume, when training is you want high performance in your EMS agency. That might require, you know, might require a lot of training, while at the same time asking people to volunteer and do this work. I guess for you, when we looked at the data, for example, we saw that training barriers of the time it took to do the training was a significant barrier for staff recruitment and retention, particularly for our smallest agencies. And that barrier seemed to decline pretty significantly as the population they served increased. Do you feel like there could be differences in the trainings that are required, dependent on kind of size of the agency or the population it serves at least, or is that just getting into some pretty tough waters?
I think that's you can have that conversation, Kelly. No, but you know, I think on those lines, you know, we a few years ago we made a move to staff ambulances with emergency medical responders and an EMT, which quality of care. I'm not a quality of care clinician. I'm not a medical doctor. I'm not going to rate that. But what it did do is it allowed an easier entry into the industry, into the profession. So to go through the EMR class and make that first step, and now you're working on the ambulance, and now maybe you want to be trained further to be able to be in the back and take care of that patient. Or maybe it's someone, and I saw some comments on how difficult it is to get through the EMT class. Well, I've heard stories where folks have taken the EMT class and they weren't able to pass the national registry test, but they were able to obtain their EMR certification. So now they can go to work on the ambulance, and maybe one day down the road, it will work out to move up, or maybe they'll just take off and go to paramedic school, or I hate to say it on this, maybe they'll go into another healthcare profession and go back to their local hometown and fill another void that's out there. But I don't know if we need to have a rural EMT and an urban EMT. I think that's a really bad idea.
Don't.
I think William here put it well. Training issue is certainly a complex problem, but we don't want to go back to the old load and go.
No.
I think that's probably a good way to put it. Yeah. I think one last question and we'll wrap it up here. And this is from Brenda. What would you most like to see happen for EMS in the next 2 years? And how do you think that could happen? I'll start with Ann.
Well, that's a great question. You know, I'd like to align all of this and, you know, somehow sustain the volunteers we have and get more, either if it's payment coming their way or, you know, we have to work on recruitment and retention. And that is $1 million question. What does that look like? You know, Gordy said it for best too. Thank goodness for these businesses in these small towns that let their people leave. You know, do we have to get more buy-in from them as well? I mean, money does talk. Is it paying these people, you know, more than they get? I think it's going to be interesting to see what comes out of this OLA audit and what the EMSRB can do. Again, they've done a nice job so far, and it's going to take all of us working together to figure out how we do go forward. I mean, that is a great question, and I really don't. I believe in volunteerism yet. You know, I know it's hard to sustain, and I get that as we're losing volunteers, but I just think if we can collaborate some of our, you know, put the silos down and some of these smaller services, maybe get that manager and share your resources, share your people, share your equipment, you know, your policies. So that way, you know, between those services, everybody is trained the same way and patients are getting the same care. That's a great question.
Thanks, Ann. I'm going to turn it to Gordon because we'll finish with Mark since he's a little long-winded.
Well, Mark, I'm giving you a run for your money today. So, you know, everything that Ann said, I think is absolutely spot on. I think of three things: the management piece, because that is going to help with the shrinking dollars that Mark alluded to coming in. You know, math is math, and it gets to a point where the math just doesn't work anymore. The other thing is recruitment and retention. I mean, thank you to all of these folks that, you know, are on call 24 hours a day, 7 days a week, trying to keep their ambulance service alive. I mean, those folks are doing it for their communities and their people. That's amazing. However, it's going to get to a point where communities within close proximity are going to have to, as Ann said, drop those silos and begin having those conversations. Is it a joint training day, you know, once a quarter or something like that? Is it working out coverage agreements with each other for, you know, to help cover your primary service areas? Is it putting some type of an agreement together like that? And the other thing is reimbursement. You know, if you're a large service or a small service, you know, when you collect 35 to 40 cents on the dollar, your fuel isn't going down in cost. Your medical supplies are not going down in cost. Your insurance isn't going down in cost. So I think that's another key piece is for sustainability is reimbursements also have to be figured out, and what does that look like? But just to summarize, collaboration, work together, think outside the box, and you know, and try to look forward down the road a few years if you can, as you have those conversations.
Mark, your thoughts?
Yeah, so I agree with both Ann and Gordy, and with Ann's comments about aligning. Look at just watching the chat and conversations that keep going around and around and around and around. And I saw one earlier about, you know, the time has come to end the reports and the studies, and we need action. And I firmly believe that action costs money. We can't do this without funding. I'm not going to specify where it comes from, if it comes from the local taxpayer, if it comes from the state government, or if it comes from Medicare and Medicaid. I think that's all still our money. It's just, where is it going to come from, and where is that gap going to be filled? However, the solutions to all of this are going to start locally. And every ambulance service in every community needs to look at themselves. And where are they? Where were they? How have they gotten to where they are? What is their future where they are? And what do they want to do? What do you want and what do you need? And if you want, if you want the gold package and you're willing to pay for it, great. Let's move forward. But we need to do this together, and it needs to be aligned, and it needs to be one concerted effort between everybody on this call, every community leader, every ambulance service, healthcare leader. We need to come together for one path forward.
Well, thank you guys. Thank you very much, everybody, for being on the panel. That was fabulous. If anybody has any questions in attendance, please feel free to email us, Center for Rural Policy and Development. Julie, did you want any parting words?
Just thank you to our panelists. Thank you for the robust discussion in the chat. Again, you can look at our YouTube page, our YouTube channel next week, and we will have this posted. And again, if you do have any questions, please let Kelly or I know. Thank you so much for joining us today, and have a wonderful day.
Thank you. Take care, all.